Welcome to AETCM, the Emergency Medicine channel. Today we'll be discussing about a young male who came to Ria with complaints of right ankle pain. So a 20-year-old male came to Ria with complaints of right ankle pain, which happened after he was climbing downstairs and there was a sudden twisting of his right ankle. So on arrival, he was conscious, oriented and obeying to my commands. He was complaining of severe pain over the right ankle joint. So I gave him an ice pack to apply over the ankle and then I continued my survey. So his airway was primary survey. His airway was patent, and there was no signs of any obstruction. Breathing part, he had bilateral equal air entry, and respiratory rate was 20 per minute, and SpO2 was maintained 98% in room air. Circulatory part, he had a heart rate of 94 per minute, and BP record was 120 by 80, and he had good peripheral pulses on all 4 limbs, including the affected limb. And at this point, we secured a 20 gauge IV cannula, and he was also complaining of pain of a score of 7 by 10. And we initiated 1 gram paracetamol. Disability part, he had a full score of GCS, and exposure part, he was provided blanket to prevent hypothermia, and the affected limb was exposed. And on reassessment after primary survey, his pain was slowly coming down, and now it is about 4 by 10. Okay. So I continue with my secondary survey.
So we have a young male who has come with history of twisting injury to the right ankle. And following that, he has got pain and swelling. It's an isolated ankle injury. He has come to. It's one of the commonest injury that we all have. The very routine. Maybe each one of you would have this sort of an injury with an ankle sprain. So my question here is that let's discuss what are the ideal first aid that you can advise the patient or the bystander or general public whenever a sprain occurs at home. What are the first aid that we can tell them to practice?
One thing is actually whenever we're suspecting a sudden actually twisting movement or something, most probably it will be a sprain. Secondly, maybe a fracture.
It can be a sprain or a fracture. Okay.
So our primary aim will be to immobilize the joint to avoid any further injury.
Okay.
So whenever possible, actually we can provide something to like a slab or a short arm splint which we can make at home itself.
Okay.
And provide so as to immobilize the joint.
First aid, the first thing will be immobilization of the joint. And the principle of immobilization, ideally one joint above and one joint below should be immobilized. Here the subtalar joint as well as the ankle joint should be ideally immobilized. Above it is very much far because it is very difficult for it in a home situation to do an immobilization like that. So what you can simply advise is affected joint can be immobilized. And how to immobilize at home, we will not get any splint. So whatever be the available resources.
You can use a pillow, towel or whatever is
available. Whatever is available, pillow, towel, or you can have a small wooden scale or a magazine or anything, or you can even roll a newspaper and it will become thick. But it's a little bit lighter for the foot, but it will be okay for the upper limb. So that is the one thing that you can tell. And what else? Avoid weight bearing in that limb. Till an X-ray is taken or till you are going to a clinician, avoid weight bearing. Elevation of the limb.
Ice pack
application. So these are the general things that you can teach anyone, those who have an ankle sprain, and when they should come to a doctor. So which are the warning signs that they should come to a doctor?
So basically we can actually remember a small abbreviation, that is PRICE, that is protection, rest, ice, compression and elevation.
That is the first aid.
So once actually we are doing all these first aid activities and this patient is still having persisting pain, that is an indication to go to the hospital.
Or to the hospital, or whether there is a deformity, visible deformity, visible dislocation can be there, visible deformity, whether it's an open fracture. And again, they are unable to bear the weight. They are not able to walk even 1 or 2 steps. And there is significant increase in the swelling. You can have swelling, but whenever there is a significant increase in the swelling and when there is a color change, all those things, they should immediately rush to the hospital and get it evaluated. So, most common thing is an ankle sprain. It's very, very, very common. Maybe in school children, it's very common. And the problem is that such an ankle sprain routinely should not cause a fracture. So, a small twisting injury like this should not cause a fracture unless and until they are having vitamin D deficiency or an elderly lady with osteoporosis. All those things. Ideally, with a minor sort of an injury, whatever we have described, with that mechanism, a fracture should not occur. But if the patient, the mechanism is too much, the force exerted is too much, they can have a fracture. But routinely, it will be a soft tissue injury. Unlikely to have bone injuries. Okay.
So after primary survey, we gave ice pack and pain relief, and so the pain is slowly coming down. So we went over the history. So history part, he was actually staying in an apartment and he was climbing downstairs. Suddenly, he accidentally twisted his right ankle, and after that, he was having pain.
No, that mechanism I wanted to know whether it was an inversion or an eversion.
It was an
injury.
inversion injury.
Okay.
And after that, he was not able to bear weight because of the pain.
The most common one is the inversion injury. Eversion injury is less likely. Inversion injury is the most common one. So, okay, then.
Initially, there wasn't much swelling, but over time, the swelling started increasing. And the pain was not subsiding, so he came to the hospital.
Okay.
But after 2 hours, he came to the hospital.
Okay. Now, this patient is in front of you. You have done your primary survey. Now, how will you proceed?
Considering this patient, actually, it's more like an isolated injury. Doesn't have any systemic or other.
You have to do an examination of the ankle joint. So, which are the key points that you will do as an examination parameters?
Suppose the patient was, if he was able to walk, we will usually assess the gait first. But since the patient was having pain, his gait could not be assessed. So, we first go with the inspection. Inspection, actually, we have to observe the joint from the first we have to look at the intent of the leg joint, how it is positioning, and then we have to observe the angle from the anterior, lateral, posterior sides. So anteriorly, the right leg was comparatively slightly swollen compared to the left side, and the skin
medially or laterally it was
laterally.
Laterally, it was more swollen. Okay.
And also skin appeared to be slightly stretched and shiny.
Okay.
And on the lateral aspect, there was a swelling over the lateral malleolus aspect.
Okay.
And medial malleoli, there was no swelling.
Medial aspect, there was no swelling. Okay.
And the posterior part also, there was no swelling, and there was no swelling over the foot, and he was able to move his fingers normally also.
Okay. Okay.
So there was the inspection part, and palpation part. There was tenderness over the lateral malleolus aspect.
Which all bony prominence that you need to examine in an ankle injury?
Ankle injury. So basically, it's actually can be used as a guidance for our imaging also. We have something called the Ottawa ankle and foot rule, in which the main prominence we have to examine is the posterior edge of the lateral malleolus and the posterior edge of the medial malleolus. And also we have to check for the base of the fifth metatarsal and also the midfoot posterior aspect, that is a dorsal aspect, that is corresponding to the navicular bone.
Navicular bone.
So suppose if you are having either one of the malleoli tenderness, or if the patient is not able to bear weight during the event and after coming to ED also, we have to go for ankle series x-rays.
Okay.
Suppose the patient is having base of fifth metatarsal along with or navicular, or he is not able to wear, we have to think about taking foot x-rays.
Okay.
So our currently our patient is having tenderness over the lateral malleolus.
Lateral malleoli, there is tenderness. So you are having a lateral malleolar tenderness and he is unable to bear the weight also.
Yeah.
So there is an indication for an X-ray as per the Ottawa angle rule. So can you just brief again Ottawa angle rule? What are the points involved?
So basically we have two rules. There is one for ankle, one for foot, and in which we have 4 points. There is any tenderness over the medial or lateral aspect, or if the patient is not able to bear weight during the event and after coming to ED, we have to take ankle series X-ray. Suppose the patient is having tenderness over the dorsum of metatarsal or the navicular part,
Fifth
metatarsal or the navicular part, or he's not able to bear his weight, we have to take foot X-rays.
Foot X-ray also. So here, what X-ray you ask for?
Here actually we have to take primarily the ankle series X-rays.
Angle series X-ray. So now let's discuss the mechanism of injury. He had an inversion
injury.
Inversion injury. So which are the group of ligaments that you suspect this patient would have got injured?
So considering the ankle joint, we have mainly 3 sets of ligament groups which stabilize the ankle joint. We have the lateral group, medial, and we have a syndesmosis.
Okay.
So the medial group is the delta ligament, which is actually comparatively a stronger ligament, and laterally we have a set of ligaments which actually strengthens that area. That is anterior talofibular ligament, posterior talofibular ligament, and also the calcaneofibular ligament. So in this, actually, the lateral part is more prone to injuries because comparatively weaker to the compared to the medial part.
Medial part, yes.
So about 85% of the ankle sprain is usually occurring on the lateral aspect.
Lateral aspect, and most commonly injured ligament is the
anterior talofibular ligament.
So anterior talofibular ligament forms the component of your lateral lateral compartment ligaments, and it is the most commonly injured. And as we said, inversion injuries are the most common one, and anterior talofibular injuries are the most commonly affected. And if the deltoid is getting involved, that means the mechanism of injury should be severe. So usually the deltoid will not get involved. If deltoid ligament is getting involved, the mechanism of injury is severe. So that is the thing. Then how will you grade the ankle sprain?
Basically, we have three grades: mild, moderate, and severe. Suppose the patient is having an injury, but he is able to walk. It is grade 1, but he is not able to bear his own weight. Then it's grade 2. But there is a significant swelling, deformity, and the patient is not able to walk. It is grade 3.
So this is a clinical grading. And why you take an MRI? Very rarely you take an MRI. How will you differentiate grade 1, grade 2, grade 3?
So basically, the grade 1 is corresponding to only mild and stretching of the ligament, and moderate is corresponding to minimal or tear or moderate tear, but not complete tear. And severe means there is complete tear with significant.
So that is grade 3.
Grade 3.
So grade 1, grade 2, and grade 3. Okay, let's go back to the X-rays. So we have seen this patient, and he had an injury to the ankle, and there is a tenderness of your lateral malleoli, and he is unable to weight bear in the ED. So we have proceeded with an angle series X-ray. Which are the views that you require?
So angle series X-ray, we go for 3 views.
Okay.
There is AP, mortis, and lateral.
Okay.
So mortis is basically AP view only, but actually we have a 15-degree inward turn in the same AP view.
Okay.
So either of usually with 2 X-rays we can most probably find most of the fractures.
AP and oblique,
or AP and mortis like that. So in that, the AP is mainly used for any soft tissue deformities and locating the minor fractures, and the lateral view is mainly for the any avulsion fractures of any anterior or posterior aspect.
Okay.
And so yeah. So we in this patient we proceeded with all these 3 X-rays, and all 3 were found to be normal limits.
Okay. So we are suspecting more in terms of an grade 2, grade 2 angle sprain involving the lateral group, and most commonly it will be the anterior talofibular ligament. That is our professional differential diagnosis. So which all group of patient needs an MRI? You need MRI for all angle sprain?
No. In cases we are suspecting a grade 3 ligament injury.
Grade 3 ligament injury, even if the conservative management can be done. It all depends upon the profession of the patient that is getting involved. He is a professional dancer, he is a sports person. So you wanted the recovery to be faster. Maybe you need a definitive diagnosis, and whether he can still continue to do the work. So all those things you need an MRI. But routinely for an ankle sprain, you doesn't need an MRI. Only thing that is needed will be an X-ray as per the Ottawa rule. But routinely MRI is not needed. From an emergency perspective, it is not needed. Only thing, maybe an X-ray we can rule out, and rarely we can need a CT. We are suspecting any bony injuries, whether any bony fracture, whether there is a chip avulsion fracture, we are not very sure. Whether there is any other tenderness, we are not able to pick it from an X-ray. Maybe for a bony injury we might need a CT, but routinely an X-ray will be sufficient enough for an ankle injury. Okay. Now how will you plan the treatment for him?
So basically our priority is initially after we getting an injury, we have to rule out any fractures.
Okay.
And then we can also try for some tests which can actually indicate any signs.
To be very specific regarding the distal neurovascular deficit, since you have mentioned, just I want to confirm it again. Distal neurovascular deficit is one thing, and dislocation also we need to look in for. You should not just like that reduce a dislocation.
There is no obvious deformity as such during our initial inspection. So also the patients have tested our dorsalis and posterior tibial artery, everything was palpable with almost same similar to the opposite limb. And also he was not complaining of any neurovascular abnormality also. So before actually our primary will be to actually more for conservative management, but we can go for some tests which we can actually indicate any signs of ligament injuries. So as we said, the most common is anterior talofibular ligament. For that we have something called an anterior drawers test.
Yeah, this all test technically speaking we should be doing it, but for a painful patient again you are doing it, it is going to be causing significant pain. So you know that it is a lateral group of ligament, and it's an anterior talofibular ligament. So there is nothing that you are going to, after knowing this, treatment plan is not going to change. So if you have taken an X-ray, you have ruled out a fracture, the dictum is immobilize the limb, immobilize that joint. So these tests are there. Anterior drawer, like in knee joint, it is totally different. But here you have a sprain. Or the only thing is that you need to have immobilize it, and anti-inflammatory agents and painkillers. That is the only thing that is needed. So these tests for theoretical purpose you can learn, but clinically speaking, we will not be doing this test for the patient that is coming. You already the patient is wincing with pain. You are again wanted to stress and see whether this patient is having pain. That is not right from the side also. Okay.
So our primary aim will be to immobilize the patient and then go for conservative management. So the treatment we opted was a posterior slab, or BK slab was put for the patient, and actually along with that he was sent home with NSAIDs, anti-inflammatory and all that for the management.
So now in the ED, you don't. Ideally, this patient doesn't need an orthopedic referral at this point of time. Only thing you have suspected a fracture or any open fracture, he needs an orthopedic referral. For this patient, how will you put a posterior slab? So what inch of POP is needed and how many layers of POP that you need to prepare, and how will you do, and as a single person or only one person available and you need to put a posterior slab and we have multiple number of persons, how will you put posterior slab?
There are actually two ways we put a posterior slab. We primarily use a 15 centimeter rolls. Multiple rolls we fold it over it by making 8 to 16 layers of slab.
Yeah, lower limb you need a little bit more.
16 layers.
Upper limb we can go for 8 to 12. Lower limb you can make 16 layers.
So with 16 layers of 15 centimeter roll, we actually measure this thing from tibia tubercle to the end of the head of metatarsal. And we have to cover that much. There is including calf, ankle, and up to the head of metatarsal. And after measuring that, we roll our POP to make 16 layers of POP. And after that, we use a stockinette to cover the area. And
if you have a stockinette, well and good. If you don't have a stockinette, you can just use the soft roll.
Soft roll. Then we can just cover with soft roll or cotton, and then we can apply the slab. If it's only a single person.
If there is a single person, he can lie down flat on his back. If there are multiple persons, if he is alone, you can ask the person to lie on his tummy and you can ask him to lift the lower limb. And with the help, and so the lower limb will be like a 7. From that, you can, as a single person, you can apply the slab. Okay. So if you are multiple number of person, you can ask one person to lift the toes and other person, the patient can himself hold it and you can apply in this way. If there are, you are alone, you can ask the patient to lie down on his tummy and ask him to lift and you can do it. Posterior slab. So, and what should be the position of the limb?
So primarily our aim is to keep it in the neutral position. There should not be any inversion, and all. There should not be any plantar or extension or flexion. So keeping the ankle in the neutral position, we have to apply the slab. And before and after checking putting the slab, we have to assess the neurovascular.
Yes.
Also, we have to check.
How long you need to ask for a posterior slab for an ankle sprain?
Usually 6 weeks.
6 weeks is maybe for a grade 3. Maybe for a grade 1 or a grade 2, maybe 2 weeks will be sufficient. Sufficient. But sending them home with a crepe bandage, that is another practice that has been happening, or maybe an ankle binder sort of a thing. So our idea is the immobilization of the joint. So crepe bandage, again the patient will walk with that and again they will come back with you with swelling. So depending upon the amount of severity of the swelling, and grade 1 maybe a crepe bandage will be sufficient. Grade 2 definitely he needs a posterior slab. The treatment option of choice is a posterior slab for an ankle sprain. Crepe bandage is all the gimmicks that the patient doesn't wanted a POP, he wanted to go for his work and all those things. They will tell a lot of things and the severity is not to that extent. So those group may be fine, but otherwise the treatment option is a posterior slab followed by your NSAIDs. Okay.
So this patient, after slab, he was sent home for the orthopedic review advice, like that.
So what we have discussed is a simple injury, that is an ankle sprain, very common ED presentation, and they can come with, the most common injury is the lateral inversion injury, and the common area involved is the anterior talofibular ligament, which is a group in the lateral group, which is a ligament group in the lateral, and the most important X-ray that we need to have is an ankle, AP, oblique, and a mortise view, depending upon the Ottawa angle rule. That is a bony tenderness and weight bearing in the ED, you can decide. Like you have for the foot also, and get an X-ray, rule out a fracture. There is no fracture, immobilize the limb. Treatment option is posterior slab. Anything else that you need to add on?
Yeah,
that's it.
Also, we can go for a Tala tilt test if there is no tenderness again.
Okay. These tests are all there, but in an ED, I don't think you should be doing all those things who is in pain. Okay.
Okay.
Thank you.
Thanks.